Right, hello everyone, and welcome to today's foundation prep session on respiratory medicine. Firstly, congratulations to all of you on graduating medical school and securing your foundation jobs. It's a really exciting time, but I also know it can feel quite daunting. So hopefully today's session will help you feel a little bit more prepared before you start. For those of you who don't know me, my name's Zara. I'm currently a clinical teaching fellow, and I'll be starting internal medicine training in August. Respiratory was actually my very first rotation as an F1. So I still remember exactly what it felt like walking into the ward on the first day and wondering what it was that I was supposed to be doing. So the aim of today's session isn't to teach you every respiratory guideline out there or turn you into some sort of respiratory registrar. Instead, I want us to focus on the practical things that will help you on the wards. So let's get started. Right, so before we jump into the session, I'll just tell you a little bit about myself. So as I mentioned, my name's Zara, and I'm currently working as a clinical teaching fellow. Before this, I completed foundation training where respiratory was actually my first rotation as an F1. I also had a renal job in foundation year 2. And looking back, I'm really grateful that RESP was my first job, as it really gave me a fantastic foundation in managing acutely unwell patients and taught me skills that I've used in every job since. I'll also be starting internal medicine training in August. So everything we'll be talking about today is still very much fresh. And hopefully I can share some practical advice that makes your transition into foundation training that much smoother. Before we move on, I just wanted to take a minute to tell you a little bit about Medics&Me and some of the resources available to you. So we have a growing library of foundation prep sessions that you might find helpful. We already have some recorded sessions on general surgery, urology, and neurosurgery, which are available on our YouTube channel. We also have plenty more sessions coming up as part of this foundation prep series, including renal medicine tomorrow, gastro on Thursday, and geriatrics on Friday. And we've also got cardiology coming next week. Alongside these sessions, Medics&Me also offers careers blogs, teaching opportunities, quality improvement and research projects, as well as mentoring opportunities. So I'd encourage all of you to kind of have a look at the website and follow us on social media to keep up to date with everything that's coming up. With that said, let's get started and have a look at what we'll be covering today. So over the next hour or so, we're going to be going through everything I think that's useful to know before starting a respiratory job. We'll begin by talking about what an F1 actually does on a respiratory ward and what your day-to-day role is likely to look like. We'll then cover how to clerk respiratory patients on your clerking shift and some of the common respiratory conditions that you'll come across. We'll also spend some time discussing the respiratory emergencies that you don't want to miss before looking at what a typical week on the rotation will look like, how to survive the ward round, and some of the practical jobs that you'll be expected to do. Towards the end of the session, I'll go through some investigations, some practical procedures, managing on-call shifts and holding the bleep, before finishing with some opportunities for portfolio building and a few wellbeing tips. And hopefully by the end of the session, you'll have a much clearer idea of what to expect when you walk onto the ward on day one. So let's start with probably the biggest question everyone has before starting a new job. What am I actually going to spend my day doing? So the good news is that despite respiratory sounding quite specialist, your role as an F1 is actually very similar to most medical jobs. So your main role is to support the team, keep patients safe, and gradually become more confident managing medical patients. So your day will usually start by preparing for the ward round. So depending on the hospital and the team, this can look quite different. So some days you'll be joining a consultant-led ward round. So your kind of predominant role is going to be kind of prepping the ward round notes. Other days you might actually be doing an independent ward round or even a registrar-led ward round. And every hospital has its own way of working. So don't worry if your experience looks a little bit different to someone else's. Before the ward round, you'll often be checking overnight events, reviewing blood tests, imaging, and making sure that you've got all the information ready for the team. And during the ward round, you'll be documenting the plan, requesting investigations, and making a list of jobs to complete afterwards. It can feel quite fast-paced at first, but I promise you'll quickly find your own system of staying organized. And once the ward round is over, that's when your jobs will really begin. So you'll spend a lot of your day chasing investigations, requesting scans, speaking to other specialties, discussing patients with your seniors, and updating patients and families. And there's a lot of teamwork when being an F1. So you'll work really closely with your nursing colleagues, physiotherapists, occupational therapists, pharmacists, and discharge coordinators, and a lot of other specialties. You'll quickly also develop your practical skills. So by the end of the placement, things that kind of seem daunting will hopefully become a part of your everyday practice. So you'll become much more confident prescribing oxygen, performing and interpreting arterial blood gases, looking at chest x-rays, and recognizing when a patient needs escalating respiratory support. The biggest thing I'll say is try not to put too much pressure on yourself during those first few weeks. So nobody expects you to know everything. They expect you to ask questions, work hard, and learn. And that's exactly what you guys will do. So let's move on to clerking respiratory patients. So you'll see all sorts of patients on the acute medical take, and I'll be kind of focusing on clerking those who present with a respiratory issue. So I'm not going to go through a full respiratory history or exam because hopefully you guys have learnt that all at medical school. But instead, I just want to focus on the extra things that are important on a respiratory ward because these are the details that can often influence management. Starting with the history, one of the first things I always want to ask about is smoking. So make sure you don't just ask whether someone smokes, try and quantify it in thinking about things like pack years, as this gives a better idea of their overall exposure. It's also really important to establish whether the patient uses oxygen at home. So if they do, find out how much they normally use, whether it's continuous or overnight or both, or if this, can completely change how you interpret the observations when they come into hospital. So it's important to know this. For patients with chronic respiratory conditions, so that's things like COPD and asthma, it's always important to ask about inhalers and also, really importantly, compliance, as poor compliance is a really common reason why people often present with exacerbations. Another question that's correlated to that is asking whether they've kind of been admitted to ITU or needed any ventilatory support like NIV. Occupational history is another one that's very easy to forget, but can also be really important. So asking about things like asbestos exposure, silica, mining, construction work, farming, etc. Obviously very dependent on the presentation. It's also important to ask about exercise tolerance, especially if we have a patient that's presenting with breathlessness. So has this changed recently? Can they still walk the same distance as normal? Or are they becoming breathless, doing much less? And finally, don't forget about previous TB or any significant respiratory infections. And this is particularly important if the patient has any chronic lung disease or relevant risk factors. Moving on to the exam. So observations will often tell you the most. They're probably the two most important ones are probably respiratory rate and oxygen. And they're the first that are important to look at when we're looking at a respiratory patient. Then we can kind of assess how hard they're actually working to breathe. So are they able to speak in full sentences? Are they using accessory muscles? Are they tiring? You can get a lot of information just by simply looking at the patient in front of you. On examination, other things that you might look for. Again, this is focused to respiratory. Obviously, there's all the other things that we are going to want to look for example, the other observations, but it's focused on respiratory things like chest expansion, listening for any added sound. So like a wheeze will point you towards like an obstructive disease like asthma, COPD. Crackles could suggest things like pneumonia, edema. So obviously this is all dependent on the clinical picture. And finally, don't forget fluid status. So it's something that we often associate with cardiology or renal medicine, but it's just as important in respiratory patients. So someone with pulmonary edema, cor pulmonale, or sepsis may be overloaded or even dehydrated, and this is going to significantly influence your management. So next, we'll discuss some common respiratory conditions that you'll come across most often during the rotations. So the aim isn't for you to kind of know every single BTS guideline before starting F1, but instead I kind of want you all to become familiar with the common presentations and more importantly, know the kind of key questions that you should ask when you're reviewing these patients. So if we start with COPD and COPD exacerbations, you'll see them very, very frequently. So one of the first things to think about is kind of what oxygen saturations should this patient actually be on. So should they be on scale 2, so saturating at 88 to 92%? And if so, we need to ensure that we're titrating them appropriately. Management of COPD usually revolves like the basics, so oxygen if needed, nebulizers, steroids, and antibiotics. With COPD patients, I'd encourage you to try and think about the patient's baseline disease. So are they taking their inhalers regularly? Have they had multiple admissions? Have they ever required NIV? Do they have any rescue medications? And if so, how often are they using it? Do they have any treatment escalation plan in place? These are all kind of clues that will tell you how severe someone's COPD actually is. And finally, don't forget to look at their previous sputum cultures. So patients who often come in with recurrent exacerbations often grow quite resistant organisms. And this again is going to influence your antibiotic of choice. Next is community-acquired pneumonia. So the main thing here really is how we're going to assess severity. And hopefully you guys are all familiar with Curb 65. Other things are making sure that we've got the appropriate cultures. If a patient's septic, that may include blood cultures too. Following your local antimicrobial guideline. As an F1, one of the biggest jobs will often be just making sure that all the basic things are happening promptly. Okay, so moving on to asthma. So asthma exacerbations are another very common presentation. So your first priority here should be assessing the severity. So is the patient improving with treatment or are they becoming more fatigued? Again, thinking about their baseline asthma, are they acutely using their preventer inhaler? Have they needed frequent steroid courses? Most importantly, have they ever required any ITU involvement and intubation? A previous ITU admission is a major red flag and should lower your threshold for escalating concerns. So we could be worried about a patient who's got possible brittle asthma here. So for pulmonary embolism, you'll become familiar with using things like the Wells score to kind of help with kind of what investigations you should order first. But the important thing to ask yourself here is the patient hemodynamically stable? So a stable patient with a suspected PE is managed very differently from someone who's hypertensive and showing signs of shock. So if they're unstable, it's important that you're going to involve your seniors early for consideration of things like thrombolysis. And when thinking about management of a pulmonary embolism, ensure that you know your local trust guidelines. So a lot of trusts still use low molecular weight heparin to treat PEs, whereby the dosaging will often depend on things like the weight and the renal function. So it's just important to be aware of that. Bronchiectasis patients often present with infective exacerbations. So one of the most useful things you can do is look back at previous sputum microbiology. So many of these patients are well known to the respiratory team and may grow resistant organisms. So previous cultures can really help guide the antibiotic choice. And finally, lung cancer. So as an F1, you're more likely to be looking after patients with an established diagnosis rather than making a new diagnosis. The key thing here is recognizing important complications and red flags. So for example, superior vena cava obstruction is something that we don't want to be missing. You'll also work closely with the lung cancer CNSs, so that's the clinical nurse specialists and also the oncology team, who are amazing source of support here. If there's one thing I want you to kind of take away from this slide, it's that you don't really need to memorize every single guideline. It's just important to kind of ask yourself, how unwell is this patient? If there's a chronic condition, what is their baseline respiratory disease like? Have they ever needed to go to ITU or required any ventilatory support? And is there anything here that means that I need to escalate early? If you start thinking in this way, you'll definitely be a safe F1. So those are the conditions that you'll kind of see day in and day out. Oh, yeah. So if we move on to the respiratory emergencies, so these are the patients that should, immediately make you stop and think and escalate. Right. Okay. So one thing I'd say is that as an F1, nobody kind of expects you to independently manage these emergencies. What they do expect is that you recognize them early on, start the initial assessment, and ask for help promptly. So whenever you're worried about a patient, don't overcomplicate it. Go back to basics, your A to E approach. Assess the patient, call for senior help early, and think about getting things done. So like things like an arterial blood gas, chest x-ray if appropriate. And these 4 things alone will hopefully get you guys on the right track. So if we talk through each one, so the first emergency I've got here is attention pneumothorax. Hopefully you guys won't see one, but if you do, it is a clinical diagnosis. So don't wait around for imaging. If the patient is clearly unstable, you should be escalating early, and you should be thinking about possible tension pneumo in a patient who suddenly becomes very breathless, hemodynamically unstable with unilateral reduced breath sounds. And if you are worried, you want to make sure you escalate immediately. The other emergency is a massive pulmonary embolism. So again, the question isn't really, is this a PE? It's more, is this patient got a PE but is also hemodynamically unstable? So if they are showing signs of shock, this is a medical emergency. And again, you want to escalate early. The next emergency is severe or life-threatening asthma. So as an F1, again, you don't need to memorize the entire BTS guidelines, but you do need to recognize when someone's becoming critically unwell. So features of severe asthma may include things like increased tachypnea, tachycardia, inability to complete sentences in one breath, reduced peak flow, and life-threatening asthma can be things like silent chest, cyanosis, signs of exhaustion, a normal or rising PaCO2 on an arterial blood gas. So if you identify any of these features, it's important that you start the initial management ASAP, but also more importantly, involve your seniors early and don't delay escalation. Massive haemoptysis is another emergency that you do not want to miss. So any patient that's coughing up a significant amount of blood needs urgent assessment. So the priority here is protecting the patient's airway, assessing how unstable they are, and again, involving senior clinicians early. So decompensated type 2 respiratory failure is another very common presentation that you guys will come across. So these kind of patients can deteriorate very quickly. So you should kind of suspect this in any patient with COPD who's becoming increasingly drowsy or confused. You don't want to just assume they're tired. You need to be thinking about CO2 retention. And an ABG is essential here. So if you're concerned, get this done, escalate early, because these patients might need ventilatory support, things like NIV. And the final point here I've got isn't really a diagnosis, it's more of a trend. So one of the biggest kind of red flags in someone whose oxygen requirement is increasing. So if you've had to increase a patient from room air to 2 liters, then 4 liters, and then a venturi, something has changed. So it's important that you're not just turning up the oxygen. You need to be asking yourself why. So this should always kind of increasing oxygen requirements should always prompt you guys to reassess the patient, repeat their OBS, examine them again, and consider a gas, and then discuss with a senior. So the key thing really is to recognize early, reassess early, and escalate early. I'd much rather an F1 call me because they're worried about someone who turns out to be okay than wait until a patient has deteriorated further. So hopefully that's given you guys an idea of the kind of conditions and emergencies that you'll encounter. So if we move away from medicine for a moment to talk about the actual job and what that may look like on a day-to-day basis. So we'll start by looking at what a typical week in a respiratory kind of tends to involve. So I thought it would be useful to include my rota from when I started F1 in respiratory, just to give you guys an idea of what a typical week may look like. So it's important to say that this is obviously very trust dependent. So every hospital organizes their department slightly differently. So your rota may look very different to mine. Hopefully you guys have all received your rotas by now. Generally though, you can expect a mixture of normal ward days, clerking shifts on the acute medical take, and on-call ward cover. So here you'll be responding to bleeps, reviewing unwell patients across various medical wards, depending on your trust. You'll also have things like your 0 days, annual leave, and teaching, which are just as important. So it's important you make sure you take your breaks and make the most of your days off. The main thing that I want to get across is that respiratory is not just ward work. You'll get exposure to acute medicine, managing deteriorating patients, and working part of the wider medical on-call team, which is a brilliant learning experience in itself and will help you guys with building your confidence. So let's talk about the ward round briefly. One thing that's worth mentioning is, unlike surgical ward rounds, medical ward rounds tend to be much longer and more detailed. You'll often review every patient on the ward, discuss things like their investigations, treatment, discharge planning, and their overall management plan. So these can easily last a few hours. So staying organized here is really important. I remember when I first started F1, I found ward rounds, they could be quite overwhelming. It felt like the consultant had already kind of moved on to the next before you'd even finished writing up the notes. So what really kind of helps is having a simple structure that you follow for every patient. And this is kind of essentially the checklist that I have that's displayed on the slide. So always start with the basics. Make sure you've documented the date, time, consultant, and your name. And you might also want to put any of the pertinent people that are with you on the ward rounds. That might be your registrar, for example. And you want to follow this with the patient's current problems and any relevant past medical history. For respiratory patients, well, any kind of general medical patient, you always want to look at the new score. Specifically for a respiratory patient, if they are requiring oxygen, you want to make sure the consultant will kind of want to know how much oxygen are they on at the moment and also the trend. So you might want to look in the last overnight or the last 24 hours or so, has their oxygen requirement gone up, stayed the same, or improved? So, yeah. So then you'd want to kind of work through the latest investigation. So have a look at the bloods. Have any recent bloods been done? Have they changed from their last bloods? Is there a trend? Is there any recent arterial blood gases? This is particularly important in patients who have come in either with an exacerbation, patients who are on any ventilatory support, or any patients requiring oxygen. Have they had any recent imaging, so chest X-ray or a CT scan? I'd also check what antibiotics are they on and whether there are any kind of new microbiology results. So this might include things like any recent blood cultures, sputum cultures, urine culture. You want to also kind of review any particular medication. So if we're thinking about respiratory, if you've got a patient who's being admitted for an exacerbation, are they still requiring nebs? Are they PRN nebs, so taking them as and when? If so, how often? Or are they still on regular back-to-back nebs? You want to be checking this because, again, this is things that the consultant will want to know. Finally, you always want to think about the bigger picture. So what's the patient's escalation status? This is particularly important, more so if a patient is becoming more unwell or not improving, but again, still important to think about. If they're not ready to go home, what's actually stopping them? Thinking about things like discharge barriers early is something that your consultants will be doing every day, and it's a really good habit to get into. So that's the overall checklist, but what does this actually look like? So this is an example of a ward round entry. So don't worry about trying to copy it exactly because every consultant has a different style and every hospital documents will differ slightly. But the main thing that I want you guys to take away from this is the structure. So before the ward round had even started, you've reviewed the observations, you've reviewed the bloods and investigations, and you can clearly see the diagnosis clear, the age, the current plan, what they're waiting, their significant background. So during the actual ward round, you can concentrate on listening to the discussion that the consultant or registrar is having and document the plan rather than trying to find the results while everyone's talking. And you'll very quickly kind of develop your own style of documenting, but having a consistent approach from day one makes ward rounds much less stressful and means that you're far less likely to miss something important. So, if we're moving on to investigations, so you'll quickly begin to familiarize yourself with things like interpreting blood tests, imaging, ABGs. So it's worth kind of being familiar with them as you're going to be requesting them fairly often. So if we start with the bloods, you'll routinely be looking at things like FBCs, urea electrolytes, CRP, liver function tests, and depending on the presentation, you might also be requesting blood cultures if a patient's septic, D-dimer if you're suspecting any kind of pulmonary embolism or deep vein thrombosis. An investigation that you'll become very familiar with is arterial blood gases, especially if you're on a respiratory rotation. Don't worry if they seem intimidating at first. These will become much better the more you practice them. When thinking about taking an arterial blood gas, as an F1, the main questions you need to be thinking about when looking at them is the patient hypoxic? So remember, you'd expect the PaO2 to be much higher if the patient is already on oxygen. So it's important to take, when you're doing an arterial blood gas, make sure you're thinking, what is the patient saturating at the moment? Are they requiring oxygen? These are all important things to think about. You also want to think, are they retaining any CO2? And if they are on the gas, is this chronic or is this new? The next, you want to kind of be looking at if there's any kind of acid-base disturbance. And lastly, you want to be thinking, does this patient need escalating? So for example, for NIV. Microbiology is another really important aspect to think about. So here, thinking about things like sputum cultures, blood cultures where appropriate, viral swabs if you're concerned about respiratory viral infection. If you're suspecting a fungal infection, often in those who are immunocompromised, you can do blood tests like beta-D-glucan and galactomannan. And also looking at previous microbiology results is very useful, especially in patients who've got chronic respiratory conditions like COPD or bronchiectasis, as these patients often can grow resistant organisms. When it comes to imaging, you'll spend a lot of time looking at chest x-rays. And I'd really encourage you guys to review every chest x-ray yourself before reading the report. Even if you're wrong, you'll be able to learn much faster by having a go at it yourself, essentially. So one of the best habits I got into on the ward rounds was kind of opening up the chest x-ray before the consultant and thinking to myself, okay, what do I think is going on here? And even though sometimes you could be completely wrong, so it's kind of your chance. You've kind of you have to see it as like a learning opportunity. So if it isn't very clear, you can then kind of ask your consultant, okay, I can't see what you're seeing. Are you able to kind of talk it through with me? Depending on the patient, you might also kind of request other forms of imaging, so things like a CT chest imaging or a CT pulmonary angiogram if you're thinking about a PE. And finally, there are also a few respiratory specific investigations that you may come across. So that's things like spirometry, although that's often done as an outpatient. Peak flow measurements, important if we've got someone with an asthma exacerbation. Bronchoscopy might be done, pleural ultrasounds. And as an F1, you're unlikely to be performing these yourselves. but it's useful to kind of understand why they're being requested and how they're going to influence management. So we've talked about the investigations you'll request and interpret. The next question is, what practical procedures are you actually expected to do as an F1 on the ward? So the honest answer is, on a respiratory rotation, you'll spend far more time recognizing when a procedure is needed, preparing the patient and looking after them afterwards than actually performing the procedure yourself. You'll become very familiar with tests like arterial blood gases, and depending on your hospital, you may get the opportunity to perform other general medical tests, so things like acidic taps, pleural aspirations, or other simple procedures under supervision. You'll also get to see a lot of chest strains. So as an F1, you're unlikely to be inserting them independently, but it's a very common on-call task to, assess them. So is the chest strain swinging? Is it bubbling? Has the drain stopped working? These are all things that you may be asked to review. You'll also come across things like procedures like bronchoscopy, endobronchial ultrasound, EBUS, pleural ultrasound. And again, you're not going to be performing these, but if you get the opportunity to observe them, I'd really encourage you guys to go along. So they're interesting procedures, and just seeing them can help you understand how these investigations and management decisions happen. One thing I'd recommend is saying yes to opportunities. So if a registrar asks you whether you'd like to come and watch a chest drain or watch a bronchoscopy and your jobs are under control, go. These are often the experiences that you guys will remember, and this is kind of how you can make the most out of your placement. Right. So now I'm going to be talking a little bit more about being on call and holding the bleep. So holding the bleep can be very intimidating. I remember this being one of the things that I was kind of very nervous about before starting F1. It feels like every time the bleep goes off, someone kind of needs you urgently. But you'll quickly begin to realize that not every bleep is an emergency. So one of the biggest skills that you guys will hopefully develop as an F1 is prioritization. So before you rush off, whenever you receive a bleep, you ensure that you take a moment to find out exactly why you're being called. Ask the nurse for a brief handover. So what's the concern? What are the observations? Is the patient stable? Has anything changed? So those few questions can really help you decide how urgently you need to attend. If you're covering multiple wards, it's completely normal to have several bleeps waiting, but learn to prioritize the sickest patients first, and don't be afraid to let a ward know that you're going to be there as soon as you finish dealing with a more urgent issue. Communication is also really important. So if you're worried about a patient, escalate early, either to your SHO, your registrar, the outreach team. These people would always want to know about someone more early rather than being called to a patient who is deteriorated. Okay, right. Other things that, okay. The next things that we'll be talking about is prioritization, how we do this. So again, prioritization is a skill. So it's something that will come more so with kind of experience. So often this traffic light framework is a way that you can kind of triage your tasks. So the red tasks would be things that are going to be quite urgent. So this might be a patient who's presenting with chest pain, a patient who's got a very significantly high news score, and this has increased quite dramatically. So amber things might be, things that you might want to do next. So this might be blood tests that are pending, a patient who might have a new presenting complaint, but they're fairly stable in their observations, patients that require cannulas and bloods, any kind of images or referrals or discussions with other specialty teams that are waiting. And then lastly is green. So these are kind of tasks that can wait. So this might be routine prescribing. So just re-prescribing someone's regular meds, rewriting a drug chart, any obvious like discharge summaries, any kind of family updates. Often you'll find, especially if you are around the wards, especially in the evening on your on-call shifts, you will find that there is a lot of family that will be waiting around to talk to you. So often these are green. So if you have got time and which in an on-call shift can definitely vary, you might want to see if you can go and update them. But again, this is green. The important thing kind of about this structure is that not everything is going to fit neatly into a box. So it's important to understand that things can change. So kind of an amber task may become red. So you might be waiting for blood, but they could come back in a patient severely hyperkalemic, and then you need to review that more urgently. Right. Okay. So that being said, let's kind of let you guys have a think about it. So, sorry, this slide, I can't, so having some tech issues. Okay, right, okay. So if we try and put that traffic light system into practice, so imagine that you are the medical F1 on call and your bleep goes off with these 4 jobs at the same time. So here you're going to try and take a few seconds and think to yourself, which one would I see first? So there isn't always one perfect answer because you usually want a little bit more information, and hopefully you've got that from what I've said. But this is exactly how your thought process should work. So if we go through each scenario, so the first one, so we've got a patient who's requiring 15 liters of oxygen. So this kind of would immediately grab my attention. So this is someone that I personally would want to assess first. So before I even get there, I'm going to be asking the nurse or whoever's giving me the handover for any observations, what their target sats are, whether they've had an A2E done already, what have they been admitted into hospital with. And once I'm there, then I would do my A2E approach myself, even if it's already been done. It's important that you do your own assessment as well. Consider investigations like an ABG, chest x-ray, and escalate early if you're worried. The next task is a patient who needs a cannula for IV antibiotics. So here it's important again to ask some questions. So you'd want to ask, why do they need the antibiotics? So are they septic and is treatment being delayed? Because then this kind of would make this task be much more urgent. And if it's routine antibiotics, when are they due? Are they due tomorrow morning? Because if so, this can easily become a green task that can wait until you're more free and have more time. Then we also have a pharmacist who's asking about a discharge summary. So although patient flow is really important and we all want people to get home, it's almost certainly something that can wait until you've dealt with kind of acute clinical issues. And finally, prescribing regular medications. Again, you want to ask one extra question. Are any of these medications time critical? So if it's insulin, Parkinson's medications, anti-epileptic drugs, or anything similar, then this will obviously change the priority again. If it's routine medications that are due later, again, these can maybe be able to safely wait until more urgent reviews have been done. So the point of this slide isn't that every job fits neatly into a box. It's about getting into the habit of asking 1 or 2 extra questions before you decide where to go. Often a 30-second conversation with a nurse is enough to kind of change your priorities. So if we finish by looking at some respiratory specific bleeps that you guys might receive. So the reassuring thing is that although the bleeps might sound different, your approach is usually the same. So assess the patient, review the observations, and think A2E, and ask yourself whether anything has changed. One of the most common bleeps you will get is, doctor, the patient is more breathless. So the first thing you want to know here is whether this is a sudden change, is this acute, or is this something that's been gradually worsening? You want to make sure you ask for all those questions that we've discussed already to the nurse on the phone. So what are the OBS? You want to make sure, has an A2E been done? You want to go yourself and examine the patient, do your basics, do your A2E, listen to the chest, and kind of consider investigations like an ABG or any repeat imaging. Another really common one is a patient's oxygen requirement, which I know we've already touched on. But again, don't just turn the oxygen up. You want to ask yourself why. Has their pneumonia gotten significantly worse? Have they developed significant overload? Could they have a pneumothorax or a PE? An increasing oxygen requirement should almost always prompt a reassessment, as discussed previously. You may also be asked to review a patient with haemoptysis. So the key question here would be how much blood. So a few blood streaks, sputum samples is a different problem from a patient who presents with massive haemoptysis. So if you're concerned about significant bleeding in the airway, this also will need escalating urgently. And finally, chest drain concerns. So you won't be expected to troubleshoot every chest drain independently, but you should know how to assess one. So is the chest drain swinging? Is it bubbling? And if something doesn't look right or the patient is becoming unwell, you want to make sure you ask for senior help. Other jobs on the slide are things that you'll also see regularly. So that would be things like reviewing arterial blood gases, prescribing oxygen, cannulas for any kind of IVs that are needed, whether that's fluids or antibiotics, reviewing chest x-rays. And these can all feel daunting initially, but I promise the quicker, eventually they will become part of your day-to-day practice. But the important thing is that if you are unsure about something you're doing, just ask. That is what your kind of SHOs, registrars are there for. And if there's one thing to remember, it's that respiratory bleeps aren't about having the answer straight away. It's about recognizing when a patient is deteriorating, doing a structured assessment, starting the basics where appropriate, and escalating early. So hopefully that gives you guys a good idea of what to expect on the wards and when you're on call. So I'm just going to finish by just talking a little bit about how you can make the most of your respiratory rotation and some of the opportunities that will be available to you guys. So I just wanted to touch on how to make the most. So there's loads of different opportunities available throughout your rotation. The important thing is to be proactive. So if you're interested in research or quality improvement, let your SHOs, registrars, or clinical supervisor know early on in the placement. There's often a lot of audits, QI projects, and research already going on, and departments are usually more than happy to get enthusiastic F1s involved. Similarly, if you're keen to attend respiratory clinics, bronchoscopy lists, or pleural procedures, let's say you have an interest in respiratory, mention it to your clinical supervisor early. Obviously, this will be dependent on kind of ward staffing levels, but if your team knows that you're interested, they're much more likely to help you find opportunities to get away from the ward. If you enjoy teaching, respiratory is also a great rotation to get involved. So kind of speak to your undergraduate medical education department affiliated with the trust that you're working in, and ask your consultants, registrars, if there's any opportunities to teach that you can get involved in. It can be anything from bedside teaching to a small group session, and it's just a great way to build your confidence and a teaching portfolio. And finally, don't underestimate the value of simply showing enthusiasm. Ask questions on the ward round, volunteer to present interesting cases to your MDT, say yes when opportunities come up. Consultants and registrars remember the juniors who are engaged and keen to learn, and that can often lead to even more opportunities later in the rotation. Just wanted to mention a few tips for anyone who's considering a career in medicine. So after foundation training, if you are interested in respiratory or any medical specialty, you'll first need to complete internal medicine training or IMT before applying for higher specialty training. Now, I'm not expecting anyone to kind of decide on their career today, but one piece of advice I would give is you do not want to be waiting until you're halfway through your foundation year 2 to start looking at the kind of self-assessment criteria for the different Royal Colleges. Even if you're not sure if medicine is for you, it's worth looking at the scoring early in foundation year 1. It helps give you over a year to gradually build things and build your portfolio rather than leaving it all till the last minute. And whether you look through the self-assessment, you'll notice it isn't about, it's not really asking for anything extraordinary. It's rewarding things that you can naturally get involved in during your foundation training. For example, teaching is a big one of part of the IMT self-assessment criteria. So offer to teach medical students, try and get feedback from that and speak to your local undergraduate department. Quality improvement and audits are another big area, particularly for IMT. It needs to be a 2-cycle QIP. Respiratory departments often have a lot of projects already running, so make sure you ask your registrar consultants whether you can get involved. There's also marks for presentations and publications. So if you come across an interesting case, ask whether you can present it to your local MDT, regional meeting, or even you can try and write it up as a case report. And finally, make the most of the clinical opportunities that are available to you. So like I said, if you are keen and interested, mention it to your clinical supervisor or even your educational supervisor early. Attend things like clinics, go to your MDT meetings, organize taster weeks if there's another specialty you're interested in. And if there's a conference you'd like to attend, ask whether there are any kind of opportunities to present or apply for study leave. The biggest piece of advice I would give is just to be proactive. So mention your interests early to your clinical supervisor, your registrars, and your consultants. People are usually incredibly supportive, but they can only help if they know what you're interested in. Before we finish, I wanted to leave you guys with a few thoughts about well-being. So starting F1 is very exciting, but it's also a very huge transition from being a final year medical student. There'll be days where you leave work feeling like you've learnt loads, and there'll be days where you go home wondering if you've done anything right. And I promise that's entirely normal. One thing I'd encourage is to look after yourself first. Eat when you can, stay hydrated, take your breaks where possible, and don't feel guilty about using your leave. You can't look after patients if you're completely burnt out yourself. Remember that you're part of a team. You're never expected to know everything. You should never feel like you have to struggle on your own. If you're worried about a patient, ask for help. If you're finding things difficult personally, speak to your educational supervisor, your clinical supervisor, colleagues, friends. There's always people around to support you. I'd also encourage you to be kind to yourself. You're not expected to be perfect from day one. You're expected to be safe, ask questions, and learn. And that's exactly what you guys will do. And finally, celebrate the small wins. Your first successful ABG, your first discharge summary that doesn't get sent back, your first ward round where you actually know what's going on. They might seem like little things, but they're signs that you're growing in confidence every single day. And lastly, I just wanted to leave you guys with some few final pieces of advice. First one being, do not be afraid to ask for help. Nobody expects the F1 to know everything, and asking for advice is a sign that you're thinking about patient safety, not that you're struggling. Secondly, be systematic. Whether you're reviewing a breathless patient, interpreting a gas, answering a bleep, having a structured approach will stop you guys from missing things. Go back to your basics, go back to your A to E, and think about the patient in front of you and try not to panic. I'd encourage you guys to make the most of your placement. Respiratory is a very varied specialty, so if the opportunities do arise to attend things like a bronchoscopy clinic, say yes. And finally, remember that confidence comes with experience. You're not expected to walk on knowing everything. Every F1 starts exactly where you are, and every shift you'll learn something new. I really hope today's session has made starting your respiratory job feel a little less daunting, and hopefully giving you guys some practical tips that you can take away with you in your first few weeks. Thank you all so much for listening. I really appreciate you giving up your time this evening. And if you guys have any questions about respiratory, foundation training, applying to IMT, or anything that we've covered today, I'd be more than happy to answer